let me just go ahead and call the meeting to order, and Lori can join in when she gets on. And we will, if it's okay with you, Sam, we will adopt the agenda by general consensus.
That is fine with me.
Okay, and we will start with waiver case management standards. If I can see everything I need to see on my screen here. Okay, so
hey Vicki, if I can jump in. Mary's not here. She's at a governor's roundtable on children's services, and I was instructed that we have to read a statement announcement before the meeting.
Oh shoot, that's right, I forgot.
So
go ahead.
Let me jump in there and touch that base.
Wonderful.
A news release announcing the date, time, and place of the June 5th, 2019 Policy Committee meeting was distributed on June 4th, 2019 to the appropriate media and other groups of individuals who have requested notification. The announcement and agenda were posted at the Department of Disability and Special Needs Central Office and on the website. Americans with Disabilities Act. There we go. The public has been notified that accommodations such as interpreters, mobility assistance, and other assistance will be provided to individuals with disabilities and special needs if requested in advance. Okay.
Okay.
All yours.
Okay, so we'll start on page 2, and the couple of comments came in from Rich Lex board about the qualifications of the case managers, and the comment was that they should be consistent with Medicaid targeted case management qualifications. Jump right in if I get any of this wrong. And Rich Lex commented that the providers should be one and the same, and I guess by that they were looking for the requirements for to be eligible as a case manager to be the same. Susan, is that what they were asking for?
Are you in the waiver case management document on page?
I'm in the yes.
Item number 2.
Page 2, yeah. Where it says that the waiver case management services let's see, the waiver case management services have to have a year of experience and a bachelor's degree.
Yes, there was a comment submitted where they really wanted to add additional requirements just to have consistency across all types of case managers, and that's not typically how we would recommend things to be, that we would exceed a requirement just for consistency. Is that how you describe it?
Yeah, so I think probably the easiest way to say it is we give providers the minimum criteria as set forth by Medicaid. If providers want to increase requirements for a specific program so that they're consistent across programs, the provider has that latitude, but we wouldn't, DDSN didn't want to increase their requirements just because one provider thought it might be a good idea for them, if that makes any sense.
Mm-hmm.
I think we looked at it as DDSN wouldn't add requirements that Medicaid hadn't added to the service.
Okay, so does the non-waiver case management service also require a year of experience?
So waiver case management requires either a year of experience working with the target population or a year of experience doing case management. Regular case management, MTCM, requires a year of experience with the target population. So there's an or in the waiver case management. There's not an or in the regular case management. So.
Okay, so the concern I guess here is that in the waiver case management, you're saying and.
I'm saying or.
They've got
or. Waiver case management is one or the other.
Okay, it says must possess a bachelor's degree from an accredited college, university, or licensure from the South Carolina DLLR as a registered nurse and have at least 1 year of experience working with disability or 1 year of case management experience.
The case management says all of that, but it doesn't give you the or. It says
requires
a year of experience working with the target population.
Yeah. Okay, well, so these requirements are actually less.
Correct.
Mhm.
Well, they're different, I think is a better way to say it.
The concern I have is that the average salary for non-RN case managers in South Carolina is higher, I believe, than what we're going to be able to pay with the lowering rates. I'm concerned that they're not going to be able to find, it's like, hey, come work for us, make less money, and have a higher caseload. You know, where we're going to find these people with this experience that are going to move? I don't know. I just don't want to make it harder by wording it differently for them to hire.
And that's exactly what we did. The case management standard doesn't give you that option of or. It says a year working with the target population. So this actually opens up your applicant pool because you could hire somebody who has a year of experience with case management that doesn't necessarily have that year of experience working with the target population.
Okay, that sounds good. So we're not putting something on them that we haven't already had.
Correct.
Okay. You good with that, Sam?
Yep.
Okay.
I understand it a whole lot better now.
Yeah. It's confusing. Page 3, Rich Lex again staff that they be required to receive an FBI check in order to simplify, I guess, meaning to go along with what the other requirements are.
Yeah, so I think Rich Lex's comment there was, why don't you just make everybody get an FBI check? And, you know, what we said was Medicaid doesn't require everybody to get an FBI check. They require you to get an FBI check if you haven't been in South Carolina for 12 months or if you work with children. So we put that requirement out there for providers. If a specific provider wanted to decide all of my people are getting an FBI check, they can certainly do that. But we didn't want to add that cost to every provider in the state because some providers may want to have, you know, an average caseload or a caseload of people that are all adults with a case manager who's been living in South Carolina for 20 years. And in that circumstance, a SLED check would suffice.
Okay. Makes sense. Lori, did you join us?
I am. I'm here.
Hey, good. We're on page 3 of waiver case management standards.
Okay. Are you guys all looking at it together online on Skype? Because I'm just on phone.
No, we're not. We don't have that set up for that right now.
Okay, good.
So we'll tell, you're not looking at anything then, right? You're not able to get to the attachments.
Attachments on Skype?
No, that were emailed on waiver case management.
No, I can get to those.
Oh, okay.
Pull it up. I've got most everything printed out, but I do not have the waiver case management. That came in a separate email, I think, right?
Okay. Yeah, and this probably will be the lengthiest, but I don't think it's going to take too long to go through these because most of them have been resolved. Most of the comments look to me as if they've been resolved, but okay, so we're talking about the National Federal Fingerprint, and again, y'all are trying, I think it's fine as it is because you're trying not to have any additional costs that they don't already have. Correct. Isn't that right, Janet?
That's correct.
Less cost and faster.
Right.
Okay. So the next one is the dispute over how many years they would have to be re-credentialed before they were re-credentialed, and it looks like y'all resolved this also by changing it from 3 to 5.
Yes. We changed it to be consistent with all Medicaid case management program requirements.
Okay, so you changed it back to 5,
Sure.
and that shouldn't give anybody heartburn.
Mm-mm.
Okay, moving right along, we're on page 4. Before we do, right above the comment, there's a part in there about DHHS is going to do the training. And I noticed that DDSN is doing the training in the non-waiver case management. And I was just wondering, does this have to be HHS training program? Or, you know, why is there a difference there?
So HHS is in the process of developing a pre-employment training curriculum that is specific to waiver case management. That curriculum will be automated, I think, at some point. I'm not really sure why it's different. It's just something that they intended to do for waiver case management, to kind of develop the curriculum.
Okay.
But what does that mean? I'm sorry, what does that mean? They're developing a pre-employment training curriculum that is specific to case management. What does that mean?
There are 7 modules. I believe that's the number. I've seen a draft of some of the modules. And it basically is training on waiver case management that was developed by DHHS. It will be coded by Blue Cross Blue Shield into a computerized training that case managers will be able to take from any web-based location.
The pre-employment training, you're talking about pre-employment of a case manager. Before a case manager becomes employed, they get this training.
Before a case manager delivers waiver case management, they receive this training.
Okay.
So HHS doesn't say you can't hire them. They say they can't provide the service until the training has been
mandatory training.
Yeah.
I was thinking of the pre-employment training that Voc Rehab. That's a term of art in my head.
I got you.
So
No.
I follow you now.
This is case management specific training about waivers. It's really kind of like introduction to the waiver, what the basic assurances are. There are several different modules. And again, HHS has not completed the training modules at this point, so there's nothing I have that I could share with you. But you know, the time frame on taking the modules as I've seen them is probably 10 to 15 hours tops.
What is the input of DDSN on that training program?
So we've been able to see a draft and comment on it, and that's as far as it's gone so far. So we saw a draft last week and provided comments on that draft, and we haven't seen it further.
It's consistent with this, right?
Consistent with, yeah.
Right.
Okay, I'm trying to figure out there seems to be a shift in roles with who's going to provide the training for what between the two agencies. I know that we're supposed to set standards. I don't really have a problem with that training, but I don't want it. I definitely think we've got to have some kind of say in that training.
Sure, and we will.
It's got to be consistent with.
Sure, it has to be consistent with their requirements.
That's right.
One of the,
Okay.
we commented on it. We meet with them pretty regularly, so I'm sure we'll discuss it at our next meeting where they are with addressing our comments.
Okay, just kind of, if you can, keep us in the loop on that too.
We will.
Okay, so the next one is the Jasper DSN board weighed in that providers must have a backup call system. So I believe y'all resolved all that because you've taken out that, a smaller, a smaller agency would have to contract with a larger one. because they would have less than 4, and you just said instead, come up with a backup plan of your own. Is that right?
Yes, that's correct. And the QPL, the fixed price bid already requires providers to come up with a backup plan that addresses staff shortages. So for the majority of providers, this is already in place.
Okay, that's wonderful. That's good. So that's resolved. On page 6, if we scroll on down, that's just a minor change, I think. DDSN removed at least annually for the assessments. So this means that there doesn't have to be an annual. Lori just emailed that she's having trouble with Skype and wants a phone number.
I'm on. That was old.
Okay.
Oh, okay. I don't know why all my email just kind of takes a pause, but anyway. I think it's user error. So we're not going to require, and an annual assessment is not going to be required, correct?
So I'm going to try to explain this the easiest way possible. The way it read in the standards was that there was an annual requirement for an assessment. So providers were thinking that meant if I do an assessment in May this year, that I have to do an assessment in May next year. When the real requirement is that a plan be completed annually, and you can't do a plan without an assessment. So an assessment is done at least annually because it's part of the planning process, but we took out the requirement for doing the assessment annually so that there wouldn't be this burden on the provider to try to keep up with when I did my assessment versus when I did my plan. You know, I may do my assessment a month before my plan in 1 year, so the provider just has to keep up with the plan due date, and they do a new assessment when they do the new plan. So hopefully that makes sense to everybody.
Yeah, it makes perfect sense.
Okay.
That's great, because you're still saying there's got to be an annual plan.
Sure.
Okay.
And we're saying you have to do the assessment with the plan. We just didn't want people to have to keep up with a separate thing for the assessment.
Yeah, that makes sense. Yeah. Okay, so on page 7, Rich Lex was asking for some examples. So, and basically there is no formal exception request.
Right.
They were wanting to know when there can be an exception to the, like if the person's homeless.
Right. So this requirement has been in the MTCM policy for the last 6 or 7 years. It's not new. It's kind of standard DHHS language, and basically what DHHS is saying is if you need to make an exception to the face-to-face contact, there needs to be reason and there needs to be documentation that the circumstances exist, that we're dealing with it through the assessment and the plan. And there's really not a formal process or necessarily an example to give them. So
Right, it's just part of the plan.
correct.
Okay. So moving on down to page 8. Now, Lori and Sam and Gary, if y'all want to discuss anything further, just stop me. Otherwise, I'm plowing on through this because they've really done a great job and put a lot of work in this. But if I'm repeating what's already on paper, it's because Gary's in the car.
I appreciate it. Thank you.
You're welcome. Okay, so on page 8, the comment was that Rich Lex requested clarification in the guidance regarding 3 months of completion by the plan. So, and my question on that was, why would not the personal representative be involved in the plan from the beginning? Why would there be a 3-month gap between when the plan is developed and the representative is
Given a copy.
Yes. Or participating, hopefully participating.
Well, the participation is required for the plan to occur. The 3-month requirement is about providing a copy to the person or representative. And because of the way the plan process works, a case manager might meet with a family, have a plan meeting, come up with what they want to have on the plan, but the plan is not dated and approved until it goes through the entire approval process. So a copy of the official plan document is not available at that plan meeting.
I got you. I understand now.
So what we did was we said, we're going to give you 3 months to give it to the family. And the thought process behind that was a face-to-face contact is required every 3 months. So at a minimum, you're going to give it to them at their 3-month face-to-face contact.
I see.
They in the interim, they would have sort of a rough draft of
Yes.
what went on at the meeting and
Yes,
and all that.
correct.
Okay.
Okay. I think that's one you're going to have to watch because, just to make sure they're completely aware of everything that's going on. I know that they don't want to be pushed to get that out, but 3 months is, quarter of the year.
Yeah. The current requirement is that the plan be provided at the next face-to-face contact, which is a 6-month window. So it's actually a shorter time frame now to get it to the family, which is a good thing for families.
Yeah, it is. I'm still, try to get it out earlier.
Absolutely.
So on page, going down to page 10, we're looking at the comment on the first one, which is meaningful communication exchange with the participant to provide one or more waiver case management activities. Rich Lakes commented this requirement to monitor only with the participant or the same representatives discourages contact with various providers' staff and does not allow quality and proper monitoring. Basically, what they're saying is they would like for the providers to be included as one of the face-to-face. Is that correct?
I think the comment from Rich Lex was they would like for the waiver case management contact to be able to be completed with a provider instead of a family. And
Right.
HHS's stance is we should be talking to participants and or their families on a monthly basis. If we also want to monitor with the provider, that's absolutely available and can be done. So it's appropriate for them to also monitor with providers, but it's not an instead of.
Now, a monthly face-to-face is required here where non-waiver is every 60 days.
So it's monthly contact, quarterly face-to-face, 6 months face-to-face in the home. The current requirements are it's actually 60-day contact. They don't do, in the current standards, there's no months, there's days. So it's 60-day contact, 180-day face-to-face, and every 365 in the home. So it kind of doubles the contact requirements.
Okay, so in the right-hand column you have written here, it is preferred that this representative, the face-to-face, a representative is a person who knows the needs of the participant. It is preferred that this representative live with the participant and or has daily contact with the participant, such as a parent, other family member, or other residential staff member. So in that case, a residential staff member would count.
For the monthly contact. Right. So if we have to do monthly contact with a person who lives in residential, we can talk to somebody who lives with them, including the residential staff. The face-to-face cannot be with the residential staff. It has to be with the person, the quarterly face-to-face. So that's the current requirement.
Okay. Well, I hope that's clear to them because to me it's not real clear.
Yeah, we're going to do some training on it just to make sure everybody understands it.
Yeah, and I agree with the face-to-face contract with the family, Because if it's just with staff, I agree with HHS's position on that, because sometimes there's a conflict of interest, and sometimes you're dealing with an employee who may be disgruntled, so you really do have to check in with the family.
Absolutely.
Yeah, so that was a good call. On page 11, there is an explanation regarding contact requirements. And that's just where you're clarified. Okay.
Yes.
Let me move on here. Okay, on page 12, this is regarding record keeping and documentation. First of all, are y'all requiring both paper and electronic records? It looks like we are.
So some of the documents for case management are electronic. If we are housing them electronically, like the plan, the level of care, those items do not also have to be printed and placed in a physical file. There are some documents that are still done on paper. There are some forms that families sign. There are our current authorization form process is a paper process. Those forms are kept in a paper file. So it's kind of a hybrid system where if we house it electronically, you don't print it and put it in the paper file, but there is a paper file that still exists for most everyone that we serve.
But you don't allow scanning in lieu of a paper chart.
We would allow them to scan it into their app if they would like to do that, but we don't require it.
Okay. And then the requirement that case records, DA requires ICF records to be maintained for 10 years. Same with health centers and whatnot. Is this part of the medical record? I mean, where do we come up with the 6-year period for retaining records?
So my understanding is that this comes out of the state archives. Is that correct?
Yes, that's what.
So I think it's the state archives policy.
I don't think that. I think the 10 years is better if it's going to be part of their medical record.
We currently have a records retention policy listing 6 years.
We have a directive.
Yeah.
That kind of governs that.
You mean the commission has a directive?
Yeah, DDSN has a directive. It's 36801 DD that outlines the records management that providers have to adhere to. And this just kind of reflects what's in that directive and refers to that directive.
And we're following the state requirements for retaining records by having that in writing and then using that time frame.
But we can change that also
Sure.
to 10.
To exceed it.
Yeah, we could exceed it for sure.
Vicki, do you think there's a healthcare requirement that we're unaware of that makes it 10 years that we should double check?
DHET requires that ICFs retain medical records for 10 years. We, as health centers, we have to maintain records for 10 years on adults and 13 on children. But I just wanted to know, what is the authoritative source for 6 years? And if it's a DDSN directive, then that's probably not.
We understand from our IT area when we've discussed records retention before that we're following the state archives guidelines on that. So it would be a state entity issuing that as 6. But certainly we can always exceed and we can double check that source. But that's my understanding. And Lori, you have that same understanding, correct?
Yes.
Okay.
Well, we'll revisit that in a directive, and then we can go back in and amend the standard if it changes. But that is, I don't know who should be deciding that, but it is a medical record, actually.
I think we will research why there's a difference, because you could have the archives not understand it's a medical record versus a basic agency record. So
that's exactly right.
We will take a look at that and double check that for sure.
Thank you. Okay, moving down to page 14. two providers questioned the requirements that are waiver specific, but that's been resolved by DDSN and clarified, it looks like.
Sure.
So we can move on from that. On page 17, there was a request for clarification for notes entered into THERAP, and but it does say case notes completed in THERAP should not be printed and placed in the primary case record.
Right.
So there is an attempt, I think, to get everything all in one place.
Sure.
Probably is what that is.
Well, we
Okay,
have
so-
people who, for some reason, feel like they should print everything out, and it just causes them work that they shouldn't have to do. So we try at every opportunity to tell people you don't need to do that.
Now, wait a minute, I'm one of those people. It's probably the older people that are doing that. I'm telling you, there's nothing like paper. But anyway, that's been resolved. So, page 18. I had a question about the, HHS, it says the guidance is that HHS will reimburse for no more than 40 units per calendar quarter per participant. And it says that prior authorizations to exceed that should be requested through applicable waiver policy director when more than 40 units is needed in a quarter. So who is the policy director? Are we talking about HHS or DDSN staff that are going to receive prior authorization requests?
So DDSN staff will receive from providers the need for exceeding the required limits, and then the policy directors at DDSN, the people who are the policy directors for the certain waivers, right? They will request the exception from DHHS. There is no, we asked them, there's really no formal format. We just need to send an email and say, we need more than 40 and this is why.
Okay. This is one that we need to keep an eye on also.
Yes, absolutely.
What is the appeal process? What if there's a disagreement?
Well, we've never had a limit before.
I
will say that when we worked with HHS on these limits, initially it started out much lower than 40. 10 hours in a calendar quarter is pretty it's pretty generous. When we looked at the amount of case management that was billed for the last several years for waiver people, it was nowhere near 10 hours a calendar quarter. So we're hoping that, we don't have a lot of people that need to exceed the limit, but I do think that HHS will work with us if we get to a point where lots of people, need more than that limit. I think they would revisit what the limit is, because it's kind of a soft limit. You can go over it with an exception.
And that would come up to the waiver administrative division?
Yeah, yes. Okay. And then we would ask HHS. DDSN will not have the authority to say they can have more than 40 units, because they actually put an edit in their system. So somebody will have to approve it, and it'll have to be manually billed in order to get more than 40 in a calendar quarter.
Well, it may come up because of the way it's going to change, and the whole job has changed.
And people in crisis. I mean, I think that's where we really are going to run a risk, is like if we have somebody who enters into a crisis situation. Sometimes case managers are involved for more than 10 hours. That's why they put the exception in there. Somebody who's stable, who's getting the same services from the same provider and things are going well, we won't even come close to it. But there will be situations I think we'll have to use it. And we can keep you updated on how often we have to request it. And if we, ever get any declinations from it,
Well, in an emergency situation, could you go over? Because there's no time frame on here.
So in an emergency situation, we would absolutely try to. One of the things that we're going to try to do is We've put a reporting process into our case notes so that at the end of each month, we can kind of see where people are, so that we can identify people who are kind of getting close, who have used a lot of units in the first 2 months of the calendar quarter. Because the way they defined it, it's not based on any given quarter, it's based on calendar quarter. So it's January through March, April through June. So
Okay,
we'll keep
well,
an eye on it from here too.
Yeah, at some point, let us know in 4 to 6 months, or whoever know, if there's going to be any problems with any of these,
Sure.
that are changing. It's gonna all change pretty quickly, so we've got to keep up with that pace. So on page 21, Georgetown Board asked for clarification, and DDSN added language to clarify, and it's about what's not billable as far as reviewing case management records. So that one appears to be resolved. On page 22, another non-billable clarification, completing activities on behalf of the participant representative related to judicial matters and court legal proceedings. And Rich Lex commented that these non-billable locations require waiver case management. So apparently y'all took it back to HHS, and this is one that I don't think is up to DDSN. I think they can determine the location where they pay for a service, but I do agree with Rich Lex, and I think it was Ralph and Aiken who said, or somebody in Aiken said, it's necessary in this situation to have appropriate case management in the judicial matters. So I imagine y'all had some conversation about that.
Yes, and I will say, for people who are non-waiver, we in the past have simply used total state money to pay for people that are court ordered to DDSN. Like, we actually do state funded case management for anybody who's judicially committed, because we know that they have a lot of interaction with court systems. Sometimes they're incarcerated. So I imagine that we'll do something like that if we run into a waiver participant. One of the things to keep in mind is, in order to get waiver case management, you have to be in a waiver. In order to be in a waiver, you have to get a waiver service every 30 days. So people who are heavily involved in the court system, like maybe they're incarcerated, they're not getting waiver case management. Those people are getting state-funded case management because they're not in a waiver, because they're not getting waiver services. That makes any kind of sense.
Yeah, but there are some people who are not in they may be in the judicial system, but
Sure.
They may not be incarcerated.
Sure.
So what their point was is that they do need representation.
Sure.
And case management relating to judicial matters frequently, or legal proceedings, and referrals and all that. So is this a CMS rule or is this an HHS thing?
My understanding is Medicaid is not allowed to use federal Medicaid money in certain circumstances, and this is one of those circumstances.
Okay, like I said, I don't think we can control that one. Gary, Lori, you're the attorneys here.
I think you're kind of right. We don't have a whole lot of control over that one.
That seems right to me too.
Okay. Although we know there's a need.
Yeah, and I think,
okay.
Right.
I think we're going to have providers present those situations to us in this kind of new world, and we'll deal with them as they come. Absolutely. If somebody needs case management assistance in a judicial matter, I think DDSN would support that and do what we can to pay for it. It won't be through waiver case management.
I really think we need to advocate for that if it's possible. Can somebody find out if whose rule is that, or is that part of our approved plan, or HHS's? I'm just not clear on whose decision that is.
Okay.
We'll
We'll find the root
Yeah.
fact that drove that.
Oh, good. Thank you. So on page 25, crisis intervention, DDSN again resolved the problem and clarified the language of the direct service crisis intervention provided for destabilization. And then there's one here about it's not billable to read mail to a participant representative. And Aiken commented that sometimes it's necessary for case managers to read mail to consumers and families, and HHS maintains this does not meet the definition of case management. But I think it's a matter of how you word what you're doing. If you are working with a participant and a representative to assist them in actions that will help them to participate in their goals in the plan, for example, that would be something they could do. Is that right?
Correct.
So it might need to say something like reading mail or other documents is not billable unless it's necessary to assist the participant in meeting their goals in the plan or something like that. I'm not trying to muddy the water here, but I think you at least, if you don't reword it, you at least need to cover it in the training.
Yeah, we will definitely cover it in the training. And I'll look at the possibility of rewording it. I think the issue from how I understand it after working with Medicaid on it is there have been in the past consumers who have case managers who go by their house once a week to read every piece of mail that comes because they can't read. And that's the service that Medicaid says is not case management. Medicaid sees that as a direct service. Somebody's coming to your house to read you your mail on a weekly basis. But of course, what you say about, somebody got something in the mail that has to do with their services and they need help understanding what that mail says and how that affects their service is absolutely something that is case management. So we don't want somebody saying, well, I'm sorry, but I can't read to you. Correct.
Correct.
So I'll see what I can do to kind of shore that up a little.
That would be great. So on page 26, rendering waiver case management services when there is no plan in place, y'all have resolved that by saying except during the first 60 days of waiver enrollment. So you added the language that clarified that one. And I believe that is all for waiver case management. So Lori and Sam, are we good to make a recommendation to the commission that that they accept these standards?
Yes, I am.
I am. We've addressed all the comments, right?
Yes.
Okay. Well, and all these things will be a work in progress as we go through, I imagine, the next however many months it takes. Okay, now I am looking for the case management standards. This one should go a little bit quicker. So on this one, if everybody's ready, we'll go to page 2. These are all just reworded and minor changes, and just to kind of separate. It looks like, can you tell us, Janet, what you're doing here? You're separating out the waiver case management things. You're changing some service coordinator to case management. Go ahead. Tell us what this is.
So a lot of the changes, or the majority of changes that are included in the case management standards, are to kind of pull out the waiver people, because our case management standards have always kind of governed both groups. It's governed people that are non-waiver and people that are waiver. And with the implementation of waiver case management, we kind of pulled out all the stuff that was in the standards that was specific to waiver people, because it doesn't need to be there anymore, because we can't bill MTCM or state funded case management for waiver people. So that's the majority of what you see. The other thing we did too was we tried to clean up any language that was, that didn't make sense. There was also a major change in the way HHS documents the approval of MTCM. There was a lot of procedural stuff in the standards about how to request active case management for people. DHHS in September issued a bulletin and said, yeah, we're not going to do that anymore. Really, you just have to meet the target population and you can bill MTCM. So we pulled that language out of the standards because people have not been doing it since September. DHHS hasn't issued the formal policy manual to go with that bulletin, but we had the bulletin, so we stopped doing it at that point. So hopefully that makes sense.
Yeah, that's really perfect. And you resolved the couple of comments that there were. You got that done. So
Sure.
The only question I had about these changes were
Real quick. Sorry, guys. I just pulled up to where I'm going to my courthouse, so I'm gonna have to get off the phone now.
okay.
And I'll talk with everybody later. Thank you.
Bye.
Thank you.
Thanks, Gary.
Bye.
So the valid driver's license. So why would, in the waiver case management, it said they need a valid driver's license. I'm on page 3, and in this one it says a driving record if applicable. And I was just wondering why a case manager wouldn't need to be required to have a valid driver's license.
So I can give you a kind of a real world example. Like, okay. I know at one point when I worked for a provider, we had a case manager who had a spinal cord injury and did not drive, but he had availability of transportation. So he didn't drive, but he was a case manager because he had the availability to get from a home visit to a home visit using alternate transportation or whatever arrangements he made. So that's kind of a reason, I guess. The idea is there may be people who do case management that don't drive themselves.
Okay, so we're leaving that up to, we're not going to say you either have to
Correct.
have this or you have to have.
Correct.
We're just not getting that deep into what the providers are going to qualify people. Okay.
Yeah, I think HHS's stance on it is if you can meet the requirements of the service, we're not going to say whether or not you have to be the person who drives your car to the home visit. You got to make a home visit, but as long as you can get there, we're good with it.
Mm-hmm. Okay, that sounds good. Lori, Sam, do y'all have anything about these changes in this set of standards?
No, ma'am.
Nope,
Okay.
I'm good.
So, are we good to make this recommendation to the commission?
I am, yes.
Okay.
Yeah.
And the last thing, well, other than the prioritized list, is the policy 73801 directive. That is, I'm getting feedback. Where is Mark? Okay, in this policy, has everybody got that policy up? We ready?
Yes.
I do.
Okay. On page 2, it talks about the resident or legal guardian, and this has come up before because we don't seem to be putting in or family member or below that it says something about a QID DDP. I don't know what that is. What is a QID DDP?
It's what used to be a QMRP. It's kind of the house manager of an ICF.
Okay. So we've got a resident or legal guardian, and there's, I'm just afraid that we have representatives or families that are not legal guardians.
Sure.
And this has come up before, and people have strongly objected to being left out of things because they're not a legal guardian. So that is a concern.
You could use the term representative.
I don't have a problem with that at all.
Instead of legal guardian,
Sure.
representative throughout.
Sure. How about if we change legal guardian to representative?
That would be wonderful.
Okay.
And it's listed like 4 times in that paragraph, so you just want to make sure, okay,
We'll do a find and replace.
Yeah, we can do that, no problem.
perfect. That's all I had on this policy, actually. Lori, Sam, do y'all have any problem with anything?
No, looks pretty straightforward to me.
Okay.
Good.
Okay, so with that change then, Lori and Sam, can we do another general consensus? Are y'all in agreement to pass this policy or to recommend it pass to the commission?
I'm in favor of that.
Ditto.
Thank you so much. Okay, the last on the list for the agenda is the list of standards to be posted for public comment. And man, these are a lot of standards. So the purpose, Pat, you remember when we started out on this journey about how we were going to do this, and we're still figuring it out, I think. We were looking at the policy being able to weigh in on prioritizing what we do next. Mm-hmm. And I think that was the main thing. It was that we wanted to look at, if you're going to send, you know, what are we going to work on first, basically, or when. This is a no-brainer because all of these are due right now. So we don't, you know, that's why I told Mary, go ahead and post these. The problem we're going to have is we're going to post them and then we're going to have like 3 business days before the next commission meeting. And it's going to be very difficult to have more than one meeting, and it's going to be very difficult to go through these in that one meeting, because when you send some of these things out, you know, like the residential standards, and we're going to have to revisit the fence situation and all that. So, I mean, it's going to be difficult to get all these done by July 1, is what I'm saying.
I think once you give us authorization to vet them, it's 15 business days of vetting. So the best case scenario, they get done by the 25th. And, and then after that, we have to edit in the comments. So
we edit as they come in so that it doesn't cause a big turnaround lag. But we will get comments the 25th by midnight, sure. I'm sure.
But that would give us, what, 3 business days to get it done?
Prior to the end of the month.
So, okay.
Let's say that would give us less than a week
to look at the comments.
Yeah. Or to even have a meeting and discuss. Yeah. I mean, we need to deliberate on some of these things, and I don't see that. I mean, if y'all have a way of doing it that I'm not thinking of, let me know, but I don't think it's possible. But I mean, I'll try. I don't know how, we can take a look at how many comments we have and get through as many of them as we can, but it just does not look feasible to me to be ready to roll with all these July 1st. So
if the committee could look at the drafts as they've received them between now and that time, then they'll be very familiar, and then the comments that we receive you could be spending your time on those though. And maybe we've talked about these changes with some targeted provider groups, and we have not received additional comments for revision thus far. I don't know the volume. We typically, as you see, don't receive a lot of comments, so I wouldn't guess that we would receive a huge volume. But if it was kind of looked at in those 2 stages, review the standards as they're written now, and then at the 25th, review the comments and then meet, that would be one approach to move forward.
Well, there again, that's not giving us but a few days, and it's too much to do in one meeting. So I'm just trying to put you on notice that starting some of these things July 1st does not seem to be feasible to me. And it's, this is why we're reviewing these standards, because we've been responsible for standards that we didn't have a say in the past, and it has created problems. So we're doing it now, and we just can't, we just can't fly through them. We've got to have an opportunity to deliberate some of these. So what you might want, because knowing how long it's going to take to do some of that, what we could do is prioritize, and just get through as many as we can. But you'll have to tell us what the priority order is going to be.
Okay.
And on some of the day standing licensing things that say things are going to start July 1, you might want to consider making that August 1.
Yeah, we got to do what you got to do. We'll let's just get them out and get the 15 days rolling for sure.
Yeah, for sure.
And then we'll get the comments. But I do see the compressed time frame at the end of June.
Yeah, and is there any way, I mean, all this is because of the end of the fiscal year, I know, but it's just so things are evolving so quickly. I don't really know that y'all have had a lot of time to get them out any earlier than you have. Isn't that right?
The residential habilitation and the licensing standards revisions were done more recently. The employment standards have been waiting for quite some time to make it to an agenda. So we probably could have batched them differently. That is absolutely correct, but some of them were more time sensitive to complete in May to have them ready now.
Okay, well, you know, we've met pretty regularly, but there again, if we need to prioritize something, then we need to do it. But this at the end of the year is, you know, I would say post. Okay. And that's what I said in my email back, just post it, because if that 3 days helps us to have another opening and a time to have another committee, then post it now. But that didn't get done, so we're now down to the very few days. So Lori and Sam, we will have, hopefully Sam, we will have very little time to pass a good many of these. And
I went ahead and I've reviewed most of them already. For whatever reason, I inadvertently reviewed these before the case management one, so.
Well, man, that's great. You're way ahead. So I think what I'm going to do is submit my comments to you, Susan, when everybody else is submitting theirs.
Sure.
And maybe that'll require less meeting time. You know, I don't know. But they're just going to be my comments and not the committee's. As long as we keep that separate, we'll be good.
Sure.
Anything that would save us time.
That's a great idea. Thank you.
That's what I'm looking for here. Okay, anybody have anything? Do we have anything else we need to do? Do we need to can we agree by general consensus to, what are we doing, to prioritize those things to be sent out for comment? And release them for public comment?
Yeah.
Yep.
Okay, anybody have anything else? Well, thank you very much.
Not for me.
Thank you, Susan and Janet, for all of your hard work. I know that took a lot of visits to HHS, but it's really, actually, it's very good, very thorough, and good job.
Thank you, Commissioner Thompson.
Okay.
Lori Manos did
Yes.
most of the speaking today.
Thank you.
I know
That's okay.
you see us, so I want to give her acknowledgement for all her work and clear, concise explanation. So I appreciate that, Lori.
Have I been calling you Janet the whole
Yeah, it's
day?
okay. I answered
I'm
to
so
Janet.
sorry.
We consider it flattering.
That's right. That's right. We do.
Well, you've done a great job with it.
Thank you.
Thank you all so much.
Thank you.
All right.
Appreciate it.
Bye-bye.
Meeting adjourned. Bye.
Bye.